The clinical effectiveness of bioactive glass has been proven extensively, and literature reports are abundant, so I won't dwell on that for too long. We've seen it in several publications that the technology works and that we get good results with it. We also know that we get up to 93% eradication of infections in all cases with a mean follow-up of 21 months. We also know that bioactive glass has a unique feature, that it's also antimicrobial, and also this has been shown in several in vitro and in vivo studies. But when we started using it, I got worrisome messages from my financial controllers that I was starting to use a biomaterial which had a cost brought with it, and they got worried that I would, let's say, launch myself into a biomaterial that would not, let's say, have a cost-effective effect in the long run. So we went to look into these aspects, and we did a retrospective cohort study in all patients that we treated with long bone chronic osteomyelitis. And we looked at a treatment group in which we used bioactive glass in a one-stage setup, and we used a control group of patients that were, let's say, operated the classical way in 2 stages with an intermittent stage of gentamicin beads. And ideally, we would have randomized it. We could not get that past our local ethical committee. So we looked at another hospital in the Netherlands that was still using the 2-stage technique in sufficient amounts, and we were unable to identify any such hospital. So eventually we couldn't do anything else but compare it with our own cohort of patients that was treated in the standard 2-stage way just before we started treating or using the bioactive glass. And the primary outcome of the study was obviously eradication of infection, but we looked at all the hospital costs that were related to the treatment of the osteomyelitis from the first outpatient clinic, so to say, to 1 year after surgery. And the 1-stage group consisted of the way you should use the bioactive glass, so extensive surgical debridement and filling up the dead space with bioactive glass. In the 2-stage group, we did it the classical way with debriding the osteomyelitis, filling up the defect with gentamicin beads, and then coming back after 2 weeks or more to fill up the defect with any kind of auto or allograft. Obviously, the 2 groups were treated the same as far as adjuvant antibiotic therapy was concerned, with 2 weeks of IV and 4 weeks of oral antibiotics, adjusted to the results of the microbiology. We had 2 groups of 25 patients each, with no relevant differences in each group. And the clinical results showed that eradication of infection was succeeded in 96% of the cases in the treatment group, so the 1-stage group, and 80% in the control group. However, this was not statistically significant. We also had some complications. In the treatment group, we had 1 femoral fracture that you see below and 4 wound healing problems. The control group showed 1 death unrelated to the infection, 1 amputation, also unrelated, and 3 wound healing problems. And here you see that femoral fracture healed after 6 months. This is the 1 year post-operative. But now we come to the most important, let's say, message of this talk. When we compared costs, we saw that the hospitalization and the surgical costs were significantly diminished. Obviously, you could say that this is a no-brainer because you do 1 operation instead of 2, but still it had to be shown, and also because we were using a biomaterial that was a lot more expensive. The gentamicin beads, they cost almost nothing, and we were also using more PET-CTs in comparison with the patients that we treated beforehand. So it was not clear from the beginning if it would be, let's say, a cost-effective measure or not. But when we took all the costs into account, you could see that on average we saved about €6,500 per patient between these two groups. So the total healthcare cost went down by about 6,500. Hospital admission was half of that cost in both groups, and we had significant decreases in also surgical cost and antibiotic cost. However, the material cost went up significantly, and also the imaging cost, as I mentioned before. And now I'm not an expert in all these cost effectiveness studies, so I had some help from people at the university. And what's important is that you can simulate, or you can make the groups a lot bigger by simulating it with, let's say, cost effectiveness software. And what you can calculate is a cost effectiveness ratio, which means that if you can show that the treatment is not only more effective than the one you compare it with, but it's also less costly. And so then you see that all the simulations end up in the southeast quadrant, which means that the new treatment is more effective and less costly. And for each successfully treated patient, you then, you then actually have a cost saving of more than €40,000. So that's where it becomes interesting. You can also do a sensitivity analysis, which means that you will vary the costs based on treatment or on cost. You can play with the surgical time. So basically this is an analysis to get rid of all the outliers, or to, let's say, make the outliers stronger in your analysis. And when you look at the first column, you see that the figures remain negative, meaning that even if you take a longer time for the surgery or whatever, the cost effectiveness is still a valid point. So that reassured my financial controllers. I was allowed to continue the use of this biomaterial. And as a take-home message, I would like to say that we've shown, not in this study, but through various other ways, that bioactive glass enables one-stage surgery in chronic osteomyelitis treatment. It's also a potent biomaterial with regards to the antimicrobial resistance problem. And this study showed that it's a highly clinical and cost-effective solution compared to traditional two-stage surgery with antibiotic-loaded PMMA beads. I must say this is the Dutch situation, so I maybe not be able to stretch this to other countries with other remuneration systems, but I think there is a valid point in saying that by doing it in a one-stage fashion, bioactive glass can help giving you a cost-effective measure of treating chronic osteomyelitis. Thank you for your attention.